Good morning, dear colleagues. On behalf of my co-authors, I would like to thank the organizing committee of having chosen the Penelope-B trial for presentation at this year's San Antonio Breast Cancer Symposium. These are our disclosures. Patients without a pathological complete response have an inferior prognosis compared to those with a pathological complete response, and this is also true for patients with a hormone-receptor-positive, HER2-negative primary breast cancer. The clinical pathological stage estrogen grade staging system called CPS-EG score identifies patients at high risk of relapse after neoadjuvant chemotherapy and can split them from a very good into a very bad prognosis, what you can see on the right side. GBG could validate these previous results on their metadatabase for the hormone receptor positive HER2-negative breast cancer patients. Those with a CPS-EG score of 3 or 2 and nodal involvement have a DFS at 3 years of 77%. And this comprises about 25% of the population. The CDK4/6 inhibitor palbociclib, in combination with endocrine therapy, prolongs progression-free and overall survival in metastatic breast cancer. The aim of the Penelope-B trial was to evaluate whether palbociclib would prevent relapses post-neoadjuvant. The trial started in December 2013. The study design is outlined here and demonstrates that the patients were randomized after completing neoadjuvant chemotherapy, surgery, and radiotherapy if indicated, and were randomized in a one-to-one fashion after being stratified by nodal status, age, Ki67, region, and the CPS-EG score to receive either palbociclib 125 milligram per day in 3 weeks out of 4 weeks for 1 year, or the matching placebo, in addition to endocrine therapy, and the endocrine therapy was given at the discretion of the investigator. The main eligibility criteria outlined here: the patients had to have residual disease either in the breast or the lymph nodes and had to have a CPS-EG score of 3 or 2 with nodal involvement. The hormone receptor status, HER2 status, and the Ki67 were assessed centrally prior to randomization, and it was preferably done on the tissue from a post-neoadjuvant residual disease, if not available from the core biopsy of the breast, and if also not available, then the lymph node for the nodal invasion. The time between completing locoregional therapy and start of palbociclib or randomization had to be elapse less than 16 weeks for surgery and less than 10 weeks for radiotherapy. The primary endpoint was invasive disease-free survival. Secondary endpoints included other time to event endpoints, safety, and compliance. Here are the statistical considerations. Initially, 255 IDFS events would have been needed to detect a hazard ratio of 0.685, which would reflect a 3-year IDFS increase from 77% to 83.6%. And with 85% power, 1,100 patients would have been required. An adaptive design would have been chosen to allow for a sample size increase, and this was done at the first interim analysis in mid-2017, and the patients were increased to 1,250 at that time, with 290 events needed. A second interim analysis was conducted last year in April at 194 events, and this was done for fertility and efficacy. And the final IDFS analysis has a nominal significance level of 0.0463. And to address the inflation of the type 1 error, statistical analysis was done using the CHW method. Between February 2014 and December 2018, 1,708 patients were screened. Of those, 1,250 were randomized, 631 in the palbociclib and 619 in the placebo arm. Of those, 1,244 started therapy. 80.5% in the palbociclib arm and 84.5% in the placebo arm completed all 13 cycles regularly. At least 7 cycles completed over 88% with palbociclib and 90% in the placebo arm. About 5% of the patients interrupted endocrine therapy, and the main reasons for early discontinuations were adverse events, which were more common in the palbociclib arm, and patients with 9% in the palbociclib and 6.6% in the placebo arm. The main baseline characteristics are highlighted here. The majority were younger than 50 years. Nodal involvement was equally distributed between the two stratification factors. The minority, only 25%, had a Ki67 at central pathology greater than 15%, and the CPS-EG score of 3 was present in 60% of the patients. Ovarian ablation was used in 17% of the patients, and endocrine therapy was used equally, either tamoxifen or an AI in 50% of the patients. This is the primary endpoint, invasive disease-free survival. And after a median follow-up of 43 months, the hazard ratio was 0.93 with a p-value of 0.525. At 3 years, the IDFS was 81.2% in the palbociclib arm and 77.7% in the placebo arm. And at 2 years, there was a larger difference observed for 88.3 versus 84%. Subgroup analysis were not different. No group could be identified with a higher benefit from palbociclib. The type of events were in 3/4 of the patients distant relapses, and 16% of the relapses were locoregional ones. Contralateral breast cancer, second primary invasive breast cancer, and death without a previous event were less common. At the time of the final IDFS, an interim overall survival analysis was planned and is shown here. The hazard ratio at this median follow-up of 43 months is 0.87 with a p-value of 0.42. And the overall survival at 3 years is 93.6% in the palbociclib arm versus 90.5% in the placebo arm, but follow-up will continue. The extent of exposure is outlined here. I would highlight the relative total dose intensity, although it was significantly different and lower in the palbociclib arm with 82.1% compared to 99% in the placebo arm. It was still satisfactory because it was over 80%. Dose reductions were more common as expected in the palbociclib arm and more common in the first part of the trial. In the latter part of the trial, there were some dose reductions, but they were less common. And in the last cycle, about 50% of the patients were still on full dose of palbociclib. This is just a brief summary of the adverse events. The majority of the patients had hematological, any grade or high grade in the palbociclib arm, and this was significantly more common with 73% for high grade and 1.3% for the placebo arm. And there was no difference between the non-hematological toxicities with high grade of about 20% in both arms. Serious adverse events were not significantly different between the two arms. There was a slight trend for more hematological and non-hematological adverse events with palbociclib. So in summary, after a median follow-up of 43 months, the addition of 1 year of palbociclib to endocrine therapy in patients with hormone receptor-positive HER2-negative breast cancer and at high risk of relapse after neoadjuvant chemotherapy does not improve invasive disease-free survival. The interim analysis for overall survival also does not show any differences. Although the compliance was lower in the palbociclib arm, it was still satisfactory, and the relative total dose intensity was over 80% with palbociclib. There were new safety signals observed. In conclusion, we can say this is the first study showing mature IDFS results for a CDK4/6 inhibitor as part of post-neoadjuvant or adjuvant therapy. To date, those results of the Penelope-B study do not support the addition of 1 year of palbociclib to endocrine therapy, and it could be that the treatment duration with 1 year is too short, but we don't know that. Long-term follow-up from all neoadjuvant CDK4/6 inhibitor studies should continue and must be awaited, and the further translation research in this study as well as subgroup analysis are ongoing. Last but not least, I would like to thank all the patients and their families who initially participated in this early breast cancer trial, all the participating sites and the IDMC. I would like to thank all the cooperating partners in this study and Pfizer for financial and drug support. And a tremendous thank goes to the team at the GBG. They did a wonderful job for completing this goal. Thank you very much.